Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section and we'll be sure to ask for you. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to now introduce our guest speaker, Dr. Felix Robles. Dr. Robles was born in the Dominican Republic and raised in San Juan, Puerto Rico. He served in the United States Army while earning his bachelor's degree from Sam Houston State University. He subsequently pursued his medical education at Ross University School of Medicine. Dr. Robles has a growing interest in the integration of artificial intelligence into clinical practice, with a focus on advancing its applications within the clinical sciences. Please join me in welcoming Dr. Robles.
Thanks, everyone, for being here today. So this project is a culmination of an idea that I had over the last summer, and pretty much the idea was that I've been learning quite a bit about building artificial intelligence models and those things, and I wanted to apply that into the clinical sciences. So, and I came up with a question. The question I had was, can I pick up systolic LV systolic dysfunction from EKGs alone? So that was a question I had. So my talk is going to evolve around that, answering that question, okay? So I do not have any relevant financial disclosure or no pertinent relationship with industry, commercial entities, or outside sponsors. I haven't received any financial aid, sponsorship, or external support related to this project. This project is going to involve the scope is going to involve open source data. I did not use any data from the hospital system. So my learning objectives is going to primarily involve in characterizing the electrical characterization of systolic dysfunction with the use of EKGs and AIs. So the main challenge here is that we have in the US, we have about 6.7 million of individuals suffering from heart failure. Out of those, 38% are initially diagnosed in the acute setting in the hospital. And out of those 38%, half of them have shown symptoms symptoms suggestive of heart failure before coming into the hospital. So there's that suggests that there's a diagnostic lag in heart failure. And one of the things is primarily is that echocardiogram is something you cannot do in a regular office. And it's resource intensive. It's a relatively easy test, but it takes to you to go to maybe a place, a lab, get a technician, schedule all those things. Whereas we have EKGs that they are pretty much everywhere. They're in your office. They are in here in the hospital on every floor. So it's a modality that is available everywhere, and it's relatively cheap compared to echoes or other modalities. So one of the things that I will be discussing here is that I'll go over, how traditional markers that we find in EKGs, how do they fare, and how do they correlate, or how do they fare in helping us identify systolic dysfunction. I also went into which other information can be extracted from EKGs and see how how that information can be used for the diagnosis of heart failure. And lastly, I will integrate all of that information, the EKGs and everything, and use AIs to help us to see if we can identify any systolic deficiencies. So, so heart failure, heart failure, is classified, is primarily classified by the diagnostic modality, Pretty much we go and see the chambers with echo. So, and we have different categories here that help us determine which treatment to give at different stages. So heart failure is not just, it's not just a weak ventricle. It's multiple things happening at once. And, in my opinion, this starts at the myocyte level. We've seen that at the myocyte levels there has been, in the past, has shown evidence of, that we see some mishandling of calcium. Seeing that the calcium release from the cell and from the sarcoplasmic reticulum is usually abnormal. So that is one of the remodeling consequences of heart failure. As well, we see at the sarcomere level, we see that myosin, alpha myosin, changes to beta myosin, and that beta myosin has different properties. Again, another result from this mishandling of ions and the sarcomere changes is that results in the blunted force frequency relationship. Energetics too, we suffer in that end from remodeling. Your mitochondria changes in a way that it decreases ATP production. And also that changes in your mitochondria also leads to the mishandling of calcium as well. Again, these changes will lead to your decreased cardiac output, and by that it will increases your sympathetic drive. But what happens with your myocytes when you get that chronic sympathetic drive is that they become lazy. They adapt to that. They start downregulating beta receptors, and in general, the results is that these myocytes, they do not respond well to catecholamines. Again, outside of the myocytes, we get fibrosis, we get a dilation of the chamber, and as a result, we can see it we can see heart failure with echoes. And this is an image just showing how the calcium is handling. It reflects in a abnormal force frequency relationship. In this scenario here, the slowing in the calcium release leads to a weaker contraction, and the increase of resting calcium inside your cells can lead to a higher risk for arrhythmias. Again, this electrolyte abnormality also is going to lead to your heart not pumping well in the right situations. For instance, here the force frequency relationship we see in a normal heart. As your heart rate goes up, the force that your heart generates is also higher, but in a failing heart, we see that relationship takes a negative downturn here, since we're seeing that as your heart rate goes up, the force of your heart is weaker. So this could explain why in some scenarios you can see some patients that would come in with reduced EF and they are just fine, but the minute they go out to do something, they are exacerbated. And again, this is covering how your adrenergic maladaptation leads to pretty much an exhausted myocyte. So again, here we can see the consequences of your myocyte remodeling, how that leads to more more structural abnormalities, and by that reason leads to help us find it by looking at with the echo. But also, this is because, throughout history, this has been a disease that's been centered towards diagnosing it with echoes. But I believe that some of those remodeling consequences can be seen in EKGs way before you see the consequences in the echocardiogram. So here I'm using EKG as a biological instrument, the same we would use echoes as a biological instrument to diagnose heart failure. So why EKG? Why I think EKGs are a great tool for this purpose is because EKGs are microscopic projection of microscopic events. For instance, these myocytes are the ones that are generating these action potentials, and they are summated, and this projection gets read in your skin by the leads. Now, we have 12 different leads, but one thing is that with those 12 different leads, we're looking at the same signal, just looking at from different angles. So pretty much EKG can tell us about those electrical consequences of heart failure. But it cannot tell us, it cannot give us any information about your volumes, ejection fraction, all of those structures, things. But it can give us, things like repolarization, heterogeneity, conduction velocity, and activation recovery time. And we haven't been specifically using EKGs as a diagnostic modalities, but we know that EKGs is showing us the results of that cardiac remodeling already. As since we know already about Q waves, what QRS is, all of those things could be a result of myocyte remodeling. So here, showing just a basic diagnostic pathway for patients that you suspect heart failure. And here we see the EKGs are there, but the primary function of these EKGs is not to give you a characterization of if somebody has a systolic dysfunction or heart failure. It's just primarily to see your rhythm or conduction. But, we are using EKGs for these purposes, but at the same time, some of our therapies are already electrically contingent. So we know that heart failure is going to lead to some electrical remodeling, but we yet don't know how to use that information for an assessment on how your systolic dysfunction is doing. And again, why I bring this up is that if we have a tool that can tell us, that can estimate if we have an LV systolic dysfunction, we can find heart failure earlier and act faster, since we have good GDMT with good mortality benefits. So again, I'm talking about the thresholds here because part of my study goes over some stratified findings. So why thresholds are important, again, it's just reiterating, they tell us the degree of the dysfunction and also guide us onto which therapies to do at different stages. So So how are traditional markers fare? So, for instance, our QRS, which is a marker we use usually for indication for ICD and those things in heart failure, our QRS is a highly specific marker, and it's a good marker for rule in, but its sensitivity is not as good. And we can see this throughout most of these markers. Most of them are highly specific, but most of them have questionable sensitivities. Now, something interesting here that in this particular study, they found that any ECG abnormalities is useful as a rule out for heart failure. So, for instance, if again, sorry. So here I have another study that's showing the same thing. Any ECG abnormalities is highly sensitive for heart failure. And here showing other studies showing you the performance of your QRSs. So here we see that the traditional markers, they are decent, but they plateau at a certain point. We can see here that the area under the curve tends to plateau around 80. And I believe that the reason for this is that information loss. For instance, once we use, when we use those markers that we use to interpret as humans, we discard the complete EKGs, and there's a lot of information that we lose on EKGs. I wanted to introduce the idea of vectorcardiograms before going further, because this is one of the tools I explored and for my study to see if there was if this vectorcardiogram markers were good enough to help us find correlate systolic dysfunction. So vectorcardiogram is pretty much a way of seeing your EKG's waveform. So we know we have 12 EKGs. A vectorcardiogram it pretty much takes those 12 leads and decomposes them into X, Y, and Z components. So X, Y, and Z is converting pretty much this electrical activity to 3D. So this allows us to compute certain markers that been found in the past to be good to be found to be good markers for electrical heterogeneity of your heart. So there's a score that can be derived from this, and it uses different parameters from this. And the reason why I'm mentioning is because I assess the performance of this GEH score and the QRS-T angle on other subsequent slides. So I also, I extracted those BCGs from my 12-lead EKGs and from my data sets, and I also computed most of the common markers that you can extract from EKGs. And pretty much my data set, from the data set, I extracted 72,000 samples that have the EF information along with the EKG information. And I use all of those samples to compute 38 features. And these 38 features are composed of your typical markers and your VCG-derived markers. So I went one by one and calculated did a correlation analysis. And out of all of the markers, the spatial QRS-T angle is the one that correlates more with your systolic dysfunction or EFs in this scenario. And this is a chart showing us our performance from our top 10 markers, and we can see that most of the top 10 markers are derived from vector cardiograms, not from the traditional EKGs. So I also went ahead and did an analysis, but putting all of the markers together and seeing, and seeing how they fare together. And I use traditional models like random forest, logistic regression, to test this. So this is what I found. And this is showing you a stratified EF. It's going from 35 on the top to less than 50 on the bottom. And we can see that they are highly specific markers, with some of the models showing some different sensitivities. And this is showing a slightly higher performance than the single features as shown in the prior slide. So again, this is the AI model part over here. So what I did with the AI model is that I took in the full EKG leads, the complete waveforms, and I also took the complete vectorcardiograms and all of the features that I derived, and I just fed it to the AI to see how well can it estimate LV systolic dysfunction. So the way I trained this was to pick up any LV dysfunction for EF less than 50, okay? So for this primary task, and this is pretty much to see if it can pick up, how it's picking up EFs of less than 50 as a whole. So for this task, my model performed well with an area under the curve of 86%, sensitivity of 77%, specificity of 80, and a negative predictive value of 92%. A positive predictive value of 54%, and for a disease prevalence of 29%. And I mean, in this in my data set. So this was the primary measurement that I did, and then I went ahead and stratified my measurements by EFs. And let me see. So in this scenario, one thing that I found out is that the model is easier to pick up the dysfunction the more severe the disease is. For instance, if you can see the area under the curve for EFs of less than 35%, we can see that is 91.18. And when we go up to EFs of less than 50%, we can see that is lower. And on this chart, we can see the dose response of this model. We can see that this trend goes higher the lower your EF is. And here I'm comparing the performance with the deep learning model compared with the performance of the model I built with the engineer markers alone. And we can see that it's obviously a lot higher. So these are some of the samples I gathered from my model. And what you're seeing here is some of these are color-coded, and primarily is the redder the color is, the more attention the model is paying to those areas. So the top one, that's a normal EKG with somebody with an EF of 60. Here we can see that the AI is not picking anything up at all. So there's no interest there, but as soon as we go below an EF of 40%, we can see that the AI is detecting plenty of things there. Again, now this color coding is telling me what the AI is seeing, but it's not really telling me what the things are. And this is one of the pitfalls of using AI models, is that it can give you good results, but sometimes you cannot, it's hard to tell why is the model arriving to those decisions. These are other samples with more severe EFs. So something funny about this. So when I first started working on this, I used to walk around with my puffing up my chest thinking that I came up with this idea by myself, but then when I started reading around, there is a whole, this problem has been studied before. As a matter of fact, the first model that was built for this problem was back in 2019, and this model was only using the EKG leads. This was not a multi-branch approach like I did, and pretty much that is the state-of-the-art model for heart failure with EKGs right now, with an area under the curve of 93%. Now, there's a catch. This model was only trained for EF to pick up EFs of less than 35%, which is a difference with my model, which was trained to pick up EF of 50% or less. Now, this is pretty much showing you how are the different models that are out there, how are their performance, and we can see that they plateau usually around 91 to 93 area under the curve. And my model sits down there at 91.8. So there, from these prior models, some folks did some studies and look into the false positives. And for some of these, they have actually found that some of these false positives were actually having LV dysfunctions when they revisited the echoes. So pretty much putting it all together, same along the lines with information extraction. We know that with our traditional markers, we dismissed a lot of information, so their performance is not that good. But once we start putting more markers together, we get more information, the performance goes up. And when we throw everything in the sink to this AI models, and the performance is pretty good. So what are the limitations of these approaches? So obviously this EKGs can identify the consequences of myocyte injuries, fibrosis, dyssynchronies, and repolarization heterogeneity. It can help you triage who should receive that an echo. It can provide ruled out support and with high sensitive AIs, since they can achieve very high NPVs. Also, it's low cost. This is something that if it's continued to develop further or improve further, is something that it can be used in an office. You have a patient with some suspicious symptoms, something that can be used in the office for screening. But I don't think we are there yet. I think there's a lot of room for improvement with this technology, but it's very promising. Obviously, EKGs can never replace an echo, but I believe it can complement it. And the way I see here is, it's complemented in a way if we can, by characterizing this electrical remodeling, because a lot of our therapies are tailored for the problems that electrical remodeling is causing. So these are my references, and this is my lecture. Have any questions?
I think I really liked your talk. It was complicated, but hey, let's break it down. There's one other person in this room that might be my age or older, and I'm assuming the two of us really know how to read EKGs really well, because that's all we had in the ancient times of Abraham Lincoln and all of that, right? So the reliance upon testing with information that could be provided by a ubiquitous test that is easy to do, low in cost, has to be considered. What is it that a physician with a lot of experience reading EKGs and good history taking skills and exam brings to the table that the BNP and the echocardiogram added so much that we can account for the largest healthcare expenditures on the planet compared to our colleagues in medicine in Europe and elsewhere in other industrialized nations? We have to be careful about how we talk about that, and folks like me with gray hair who say that we did it better, blah, 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 all that, and I walked to church and school through the snow and all that. But what I like about the talk is that you're bringing hard data to the table about what is it that a gray-haired man like me can't articulate about what I knew without the BMP and without the echocardiogram that is being conferred in written form to you today, that maybe was our gut clinical instinct based on a lot of hours at the bedside with limited information and understanding the natural history of disease, and in this case, chronic heart disease with heart failure. So I see you looking at a lot of fancy data that helps me confirm and feel better about at least what I knew at that time. And so maybe what we can conclude about what you're saying is that there is still good data to be conferred through the surface electrocardiogram, yes, and that not obtaining it might be unwise, that it can be useful in the clinic long before you have done more advanced testing, going straight to the echo, to the BMP, without even having looked at the surface electrocardiogram. Maybe that's what I'm taking a little bit more of. Is that, am I getting the gist of your talk?
Yes, that's exactly what it is. We have this modality that's being used a lot traditionally, but I feel like there's still a lot more that we can extract from that modality. I feel like, in my opinion, is for this purposes is underutilized.
Thank you.
All right. If you have a question and you're viewing online, please enter it into the Q&A section, and we'll make sure to get that asked for you.
Hey, Dr. Robles, really appreciated your presentation. It's really nice to see innovation in medicine, and I just wanted to comment and ask you a question. Comment was on, I really appreciated how you said that AI in This model that you've presented has good results, but it has it can't tell us why. That's one of the pitfalls that we see in AI, and I think we see that right now as AI is in whatever phase it's in. But I just wanted to know your thoughts on, how do you envision this model in terms of what
Can you
role
raise
it
your
will
voice,
play
please?
in being incorporated into clinical practice in modern medicine? Because right now, on the cardiology side of things, we're seeing like fellowships in EKG, artificial intelligence in EKG. So I just wanted to hear from you. How do you envision this model being incorporated in our day-to-day tasks?
I would say a model like this, knowing that, because I built this model and I know its limitation. And the way it is right now, I don't think is at a point where you can put it out there. But I can, after I completed this project, I did some other experimentation with stronger architectures. And I can really see that if you increase the power of the model, the performance will increase, and it might get to a point where this might be a tool where you can put it in clinical practice. But, one thing that we have to caution with this model is that, where are you going to put it? You gotta know to put it in a place where the disease prevalence is similar to the disease prevalence of the data set, because you get more consistent results with that. Also, once you develop a model like this, you validate it with your own data set, but also you have to go out there and validate it in the community, because you may get different performances depending on where you're at, or depending on the equipment that was used to get these EKGs. That there's some techniques that we use to make these models more robust to equipment differences. But still, you have to be cautious about those things and validate properly. But I strongly believe that, in the future, we may see some of these technologies making their way into our clinics. But I don't feel like we are there yet.
I just have a comment. I really enjoyed this study. I can see the hard work you put into it. And I like the creativity in it and the novelness. And I can see the insight on electrophysiology mechanics and early use of AI in medicine, which is wonderful. I can see its use in the near future if you continue to work on its validity and get it validated like by national and spread it around maybe in like it's going to be similar to the D-dimer, where still high-risk patients are going to need the the echocardiography, especially it being a readily available device, not invasive and all of that. But maybe in the outpatient settings like primary care, initial screening, or patients who are low risk, we don't want to give them the extra cost of echocardiography. It will be wonderful, or maybe like internationally in low resources countries, it can serve as a D-dimer in low-risk patients. So thank you very much for thinking about that and adding that to the medicine. If it's approved and validated, it's certainly going to have a high value.
Thank you for this presentation, Dr. Robles. It's very interesting, and I especially like the vectorcardiogram aspect of it and how you integrated that with regular 12-lead ECG and everything. I thought that was really cool.
Yes.
AI and ECGs are such a growing field at this point. You can even implement that in diagnosing early cardiac amyloidosis and other pathologies from there. So it's no surprising that heart failure is also in the horizon here. Do you anticipate that, given how progressively improving these models have become since 2019, 2026, you've made your own model, that ECG diagnoses will almost nearly completely be fully AI and almost be that accurate to the point that, human input will not be as necessary or as prominent over top of it?
I believe that, there's a lot of information in the EKGs that are not, that we cannot perceive. And that is most of the information that is in the EKGs. So I feel like machines will be better than us to read EKGs, just given that fact that there's a lot of information in those things that we can't even perceive, but the AIs can.
Thank you, Felix. It's exciting to see what you've been up to and to see your passion in your presentation. I think it's kind of like an obligation if you discover something, create something, like maybe you see a great case in the hospital to make sure that's out in the public, published in some way. Can you update us on, are you pursuing publication with this? Who's your mentor? And then it's awesome that you have this statistical background. Where did you get your stats training?
Well, I learned by myself pretty much. I thought this, when I was starting medical school, I was hearing a little bit about machine learning. That's what it was called back then. And also back then I was big into music. So I came up with the idea that I wanted to learn AIs just to make models that can make me music. So I learned programming just by watching YouTube videos, and then I tailor it just primarily just to just learn the things that I need to build AIs. That's all I did.
So do you have a mentor for your project, and are you pursuing publication? It's good to have a final deliverable after all this work that you've done.
Awesome, thanks. You asked if I have a mentor?
Yeah, and are you pursuing publication?
Yes, I am pursuing publication, and I don't have a mentor for this project. This was one of those things that I was when I came up with this idea. It was one of those things that I was very passionate about it, and I just jump into it until I got it done. But I was just too excited to ask for help.
Yeah, that's cool. But definitely, like you admitted, you found out that there's others doing this, coming up with models. So
Yes.
I think that'll be an important next step, is to get connected with others doing this as well, and they can help you take it to the next
Yes.
level and publish it too. Yeah.
Yes, sir.
Okay, thank you, Dr. Robles.
Thanks, everyone.